Hello everyone, and welcome to HLS Pharmacology. In this presentation, we will be discussing different therapeutic approaches used for the treatment of different types of anemia. Note here that this presentation accounts for 2 in-class sessions. Just to remind you that the reference for this lecture in your textbook is Chapter 42, Drugs for the Treatment of Anemia. In general, different types of anemia have common signs and symptoms that mainly result from the reduced delivery of oxygen to tissues. And these signs and symptoms include fatigue, dizziness, which are the most frequent symptoms of anemia, and they can also be cardiovascular, including palpitations and tachycardia. They can also involve shortness of breath, pallor or paleness, feeling cold all the time, and probably other sleep disturbances. Okay, so anemia is characterized by a wide spectrum of symptoms. Note here that in cases of advanced or severe anemia, patients might start suffering from more serious symptoms, including chest pain, angina, or even can develop myocardial infarction. So anemia, just like fever, is only a sign that requires further investigation to determine the underlying etiology. See, remember, fever is picked up clinically, but is not a disorder by itself. It reflects an underlying infection or an ongoing inflammatory process. The same thing is with anemia. It only reflects that there's another problem, another etiology that is leading to reduced hemoglobin concentration. This is often missed by physicians in practice in the same way that they fail to seek the etiology of fever. You know, some people just treat fever symptomatically with antipyretics rather than digging deep to know what is the underlying cause of fever. Accordingly, it's very important to identify the type and then the cause of anemia to initiate appropriate treatment. So basically, there are only 3 major causes that can result in anemia. Those are blood loss, destruction of the RBCs, or what we call hemolysis, and a decreased production of RBCs in the bone marrow. Each of these causes includes a number of disorders that require specific and appropriate therapy. Another way to look at this is by classifying anemia based on the corpuscular volume of red blood cells, which you are familiar with as the mean corpuscular volume, MCV, which I'm pretty sure you've covered in physiology. So based on the MCV, we can classify anemia into microcytic anemia when the MCV is below 80 femtoliter, indicating that the mean volume of each red blood cell is less than 80 femtoliters. Macrocytic anemia, characterized by enlarged red blood cells when the MCV is more than 100 femtoliters, and then normocytic anemia, where the size of red blood cells is normal. The main cause of microcytic anemia is iron deficiency anemia. Of course, there are other causes, including anemia associated with chronic inflammation or some hereditary types of anemia, such as thalassemia. With macrocytic anemia, we usually further divide it into megaloblastic or non-megaloblastic anemia. Here, megaloblastic refers to enlarged nuclei of red blood cells, and megaloblastic anemia, which is more common, is usually due to either vitamin B12 deficiency or folate deficiency. And lastly, normocytic anemia can also be subdivided based on the reticulocyte counts uh, into several subtypes. For example, normocytic anemia associated with high reticulocyte counts is usually a consequence of hemolysis. Okay, different types of hemolytic anemia, and so on and so forth. So diagnosing and identifying the main cause of anemia is very critical for the treatment, as we will see in the next slides. So in this lecture, we will discuss different options that we have for the treatment of anemia. Of course, as we mentioned, this depends on the cause of anemia. For example, iron deficiency anemia is corrected by providing iron supplementation. We have other vitamins that we can also use for the treatment of anemia, such as folic acid or vitamin B12. And then there are more advanced therapies of severe anemia, such as erythropoietin, or even specialized therapy to treat certain types of anemia, such as sickle cell disease, that is treated with hydroxyurea. Always remember that one of the fastest, reliable, and commonly used methods for the treatment of anemia is blood transfusion, and just basically replacing the reduced amount of red blood cells into the patient. This is very useful in the treatment of hereditary anemias such as thalassemia, for example. Let's start talking about iron. So, iron is mainly obtained through diet. The average amount of iron that is contained in diet per day is about 10 to 20 milligrams of iron. This is on average. The iron that you consume through diet is then absorbed from the gastrointestinal tract at a constant rate of about 1 to 2 milligram iron per day, which is around 10% of the daily dietary intake. Iron is then stored in multiple organs and tissues in the body, starting with the intestinal mucosal cells themselves as it's being absorbed, and then in other tissue organs such as the liver, the spleen, bone marrow. And iron is stored in these tissues in the form of ferritin, which is an iron protein complex. Okay, so ferritin is just basically a complex of proteins bound to iron. This is how we store iron in these tissues. Now, in order to transfer iron throughout the bloodstream into different tissues after it's been absorbed from the gut, iron is transferred in a transfer protein called transferrin. Okay, so transferrin is the iron protein complex that is responsible for the delivery of iron to multiple tissues in the body. Note here that to keep it balanced, we also lose about 1 to 2 milligrams iron from desquamation of epithelia, dead tissues, lost tissues daily that get out in stool, etc. So we reach a state of balance, is that the daily intake is in equilibrium with the daily loss, while the iron stores in different tissue bodies are okay. Okay, that's how iron can be used for heme synthesis and consequently hemoglobin synthesis and RBC's maturation. It's very critical for that process. So iron deficiency, which is, by the way, the most common nutritional deficiency, results from a negative balance of iron stores in the body, which results either from reduced intake of iron or increased loss. Okay, so once you have uh, an imbalance in iron levels between the absorbed and the lost by the shedding of epithelial cells, etc., uh, you will start depleting iron stores in bone marrow, liver, spleen, and other tissues. This imbalance can result from a variety of reasons, including the acute or chronic blood loss, okay, because with losing blood, with bleeding, for example, you will lose a large quantity of RBCs harboring lots of hemoglobin, which contains lots of iron. This is one of the places where iron is stored in the body. So this goes under the increased loss. Um, Other similar reasons include excessive menstruation or menstrual disorders in states of pregnancy or in periods of accelerated growth in teenagers as they start sprouting. Uh, Usually, those children will have an increased requirement of iron that surpasses the daily iron intake in the diet. Okay. Now, in addition to the general signs and symptoms of anemia, such as dizziness, palpitations, etc., iron deficiency anemia can be associated with some characteristic symptoms, such as cholunikias or curvature of the finger and toenails, okay, as you can see in the picture. Pica, which usually happens in children with iron deficiency anemia, which refers to hunger or seeking ice, dirt, and paper. Those children literally will start putting sand in their mouths. And lastly, patients with iron deficiency anemia can develop soreness and cracking at the angles of the mouth and glossitis as well. Okay, so these symptoms are kind of characteristic for iron deficiency anemia. So how can we solve this problem that results from iron deficiency? Simply, supplementation with elemental iron would correct iron deficiency and consequently correct the anemia. The main recommendation, the main rule of how to replace iron in someone with iron deficiency anemia is to provide 150 to 180 milligrams of elemental iron every day, usually divided on 2 to 3 doses per day. Okay, this is very important. This is the main guideline of how you will be treating people with iron deficiency and iron deficiency anemia. Iron can be given through two main routes, either orally or intravenously. Of course, it's given orally most of the time. And that's why after oral administration, iron is adequately absorbed from the gut. The main site of absorption of iron is the duodenum, okay, which is the first portion of the small intestine. Acidic conditions in the stomach helps keeping iron in the reduced form. Okay, so iron exists in two forms, either ferrous form, okay, which is the reduced form, or ferric form, which is the oxidized form, okay? So the ferrous form, which usually exists in the gastric acidic environment, is more readily absorbed, right? So passing through the stomach facilitates the process of absorption until the reduced iron goes into the duodenum and is then absorbed into the portal vessels. Note here that the amount of iron that is absorbed from the small intestine depends on the current body stores of iron. Okay, what does that mean? It means that if iron stores are adequate, if they are enough, normal, we don't need more iron, then the extent of iron that is absorbed from the gut is minimal, and it's in a normal person around 10%, as we've mentioned. However, if someone has severe iron deficiency, then the percentage of iron that is absorbed from the gut will become higher and higher. In addition to that, is that uh, uh, the relative percentage of iron absorbed from the gut decreases with increasing the dose of oral iron. So in that case, we have an inverse relationship. Note here that with the intravenous iron, we don't deal with all absorption percentage um, uh, process because intravenous iron is directly administered into the bloodstream and can then circulate uh, fastly, rapidly, and directly into the organs that require iron for its functions, such as the liver and the bone marrow. So, as we mentioned, that iron can be given either orally or intravenously, and accordingly, we have different preparations. The common oral preparations of iron include ferrous sulfate, ferrous fumarate, ferrous gluconate, which is very commonly used for the treatment of anemia, polysaccharide iron complex, and carbonyl iron. All of these preparations are available orally. While on the other hand, there are several other preparations that are given by injections, including iron dextran. Note here that, as you would expect, replenishing iron stores might take more time when iron is replaced orally. Okay, so the oral treatment is very slow and takes weeks to correct iron stores and then to correct the anemia. While on the other hand, parenteral iron is faster. However, we only use parenteral iron in patients who cannot tolerate oral preparations of iron. They have severe side effects from that, so you have to switch them to IV. Or we use IV iron in combination with erythropoietin for the treatment of anemia caused by chemotherapy or chronic kidney disease, as we will discuss later in this lecture. As we mentioned, oral supplementation of iron is the mainstay of the treatment of iron deficiency anemia in most patients. That's why it's important to take a look at the available preparations of oral iron and discuss some of their characteristics. So you can, from this table, you can see that ferrous gluconate, okay, contains 12% elemental iron. Note here that all these different preparations of oral iron contain different percentages of how much elemental iron is available at each pill of the drug. This is very important because you will have to calculate um, the percentage of iron that is the actual amount of iron that will be given to the patient. So, for example, a 200 milligram pill of ferrous gluconate has only 12% elemental iron, which means it has around 24 milligrams of iron. Okay, remember that the daily dose that a patient with iron deficiency anemia is required to have is around 150 milligrams, right? We mentioned that at the beginning. So ferrous gluconate has the lowest amount of, or the lowest percentage of elemental iron. Ferrous sulfate, okay, on the other hand, has 20% elemental iron and is actually the most commonly used oral iron supplement, especially that is available at a very low cost and good effectiveness and tolerability. Ferrous sulfate anhydrous has a 10% more elemental iron, okay? And it's available as extended release formulations, okay, that can be given only once daily. Uh, Note here that one of the main problems with iron oral supplements is that they have a strong taste, and that's why we have now preparations such as ferrous fumarate that has almost no taste compared to the other iron salts. Now comes to the last two preparations, which are carbonyl iron that contains 100% elemental iron. Okay, so that should be easier when you calculate the dose of these drugs. These compounds are for sure more expensive than ferrous sulfate. However, they are less toxic and slowly absorbed from the gut, so they can be given every 1 to 2 days. And lastly, polysaccharide iron complex also has 100% elemental iron and has no taste or odor completely, but it has similar bioavailability as ferrous sulfate. So depending on the case that you are treating, you will choose the best available therapy. Of course, here cost plays an important role because, as we said, you will require months of treatment with elemental iron, which means the patient will consume a fairly large amount of the drug. So you have to pay attention to the cost of therapy. Okay, let's practice some of the concepts that we've just discussed. The question here says that which of the following iron supplements contains the highest percentage of elemental iron? And just by going back to the table, you can immediately spot, I think, that the answer to this question is B, right? Because carbonyl iron has 100% elemental iron in its formula. Here's a more application question. Let's say that there was a 60-year-old female patient that presented to the primary physician clinic complaining of dizziness and fatigue, which are symptoms associated with anemia. And you, as a physician, you decided to run laboratory testing that came back to you indicating that the patient has iron deficiency anemia. So you decide to give oral iron supplementation. Which of the following would be the most appropriate dosing for this patient? Okay, so let's take these choices one by one. Remember here that the goal of treatment is to provide 150 to 180 milligrams of iron per day, okay, daily. This is your therapeutic goal, as we mentioned at the beginning of this lecture. So you know that ferrous fumarate uh, contains 33% iron, so 33% of 325 milligram daily is about 100 milligram elemental iron every day, and that is less than 150 milligrams, so this choice would be wrong. Ferrous gluconate contains 12%, okay? Let me write these down for you again. This is 33%, and for B, it's 12%. So 12% of the 256 milligram once daily means it's also something lower than 100 milligram per day, and that is wrong too. Polysaccharide iron complex consists of 100% elemental iron. Okay, so out of the 150 milligram dose of the drug, we have 150 milligrams of iron, elemental iron. However, the question tells you here that it should be given 2 to 3 times daily, which means you have to multiply this by 3, meaning that the total iron dose per day will be 350 milligrams. Okay, this is also too high. We don't want to use too low or too high. Last choice says that you can use ferrous sulfate at 325 milligram 2 to 3 times daily. You know that ferrous sulfate has 20% elemental iron. This means that in each tablet of 325 milligram iron, you will have something around um, 60 milligrams iron. Of course, this is rough numbers. You can do the calculations. And if you give this 3 times a day, 2 to 3 times a day, then you will be treating the patient at a range of 150 to 180 milligrams per day. That's why the correct answer to this question is D. So it's very important to know the characteristics of the oral iron supplements. Of course, iron replacement therapy has some adverse effects. The most common adverse effects would be GI disturbances, such as abdominal discomfort or constipation, nausea, and diarrhea. Note that the majority of patients will complain of constipation. In addition, they will develop dark stools. In certain cases, especially with intravenous iron, fatal hypersensitivity and anaphylactoid reactions can occur in patients receiving intravenous iron, such as iron dextran, and that can be definitely life-threatening. You can avoid that by giving the patient a very small test dose of iron dextran. Okay, you inject the patient with a very low dose and see if they develop an allergic reaction before you continue administering the full dose. Note also that iron should not be used or should be used with caution in patients with an active or an ongoing bacterial infection. Can you think why? Last thing about iron that we will be discussing in this presentation is that while we don't want to treat a patient with insufficient amount of iron, we also don't want to overdose the patient because excessive iron is associated with toxicities. It is unlikely to get to develop iron toxicity from excessive administration of oral iron supplementation because you will end up losing a high percentage of iron in stool. Remember that we said absorption of iron depends on the levels of iron stores, so that percentage of iron absorbed is tightly controlled. However, iron toxicity happens due to frequent blood transfusions, and this happens with patients with thalassemia, for example, because those children will require frequent blood transfusions, and they will start building up iron in their tissues and organs. Fortunately, we have a chelation treatment, a drug called deferoxamine, that is used to reduce iron toxicity resulting from increased iron content in the body. And this can be used for both the acute and the chronic toxicity of iron. Let's now move on another drug that we can use for the treatment of anemia, and that is folic acid or folate. Now, folic acid is essential for a number of functions in the body. That's why it's required that it's kept at the normal concentrations in the body. However, the development of folate deficiency is a common disorder, usually resulting from increased demand of folic acid. This happens especially during pregnancy or during lactation. On the other hand, you can also develop folic acid deficiency in patients who have either reduced dietary intake of folic acid or develop poor absorption of folic acid from the gut due to a malabsorption disorder or another intestinal pathology. Chronic alcohol users also suffer from folic acid deficiency. And remember that certain types of pharmacological therapy can result in folic acid deficiency. One of those is the use of dihydrofolic or dihydrofolate reductase inhibitors, such as methotrexate. Okay, remember we've discussed the chemotherapeutic agent methotrexate when we discussed anti-cancer chemotherapy. We mentioned that methotrexate interferes with the activation of folic acid and can result in severe folic acid deficiency that is treated by supplementing folic acid to patients who suffer from that. Other drugs that can cause folic acid deficiency include DNA synthesis inhibitors such as the immunosuppressant azathioprine or the antiviral zidefurin. These drugs can cause folic acid deficiency as an adverse effect. Lastly, there are a set of drugs that will interfere or prevent the absorption of folic acid that is consumed in the diet from the gastrointestinal tract, and this include the anti-epileptic drug phenytoin and the barbiturate phenobarbital. So from this slide, several different causes can result in folic acid deficiency and consequently in folic acid deficiency associated anemia. So here are the consequences of folate deficiency. Remember that folic acid is essential for the synthesis of amino acids, purines and pyrimidines. And purines and pyrimidines are the basic building units for DNA and RNA, meaning that patients who suffer from folate deficiency will have reduced RNA DNA synthesis and reduced proliferation or proliferative capacities of most rapidly growing tissues in the body, including the bone marrow. This results in reduced formation of red blood cells and the development of megaloblastic anemia. Remember that folate deficiency anemia is macrocytic, and meaning that MCV or mean corpuscular volume is more than 80 femtoliters, and of those, um, the macrocytic anemia associated with folate deficiency is megaloblastic. Okay, so just some quick information about folic acid. Um, Remember, we said that the main site of absorption of iron is the duodenum. On the other hand, the main site of absorption of folic acid from the gut is the jejunum, and that's why folic acid can be administered orally. Folic acid is non-toxic, usually associated with very minimal adverse effects, even if it was used at high doses. And unlike intravenous iron, when folic acid is administered intravenously, it is not often associated with hypersensitivity, so it's fairly safe. That's why folic acid supplements are commonly and widely used, especially, for example, before pregnancy. Most ladies in their reproductive age that are planning to get pregnant are usually advised to take folic acid supplements for 3 months. And that takes us to another drug that is used for the treatment of anemia, which is vitamin B12. Uh, Again, deficiency in vitamin B12, similar to folic acid deficiency, can result in macrocytic megaloblastic anemia. Vitamin B12 deficiency can be mainly caused due to a low dietary intake. Vitamin B12 is usually available in high protein sources such as red meat. That's why vegetarians or vegans usually suffer from vitamin B12 deficiency. And that is an example on how low dietary intake can cause vitamin B deficiency associated anemia. Remember now that the absorption of vitamin B12 from the gut undergoes a special process. First of all, vitamin B12, as it's traveling through the intestine, it is absorbed. Its main site of absorption is the terminal ileum, okay, the last section of the small intestine. But for it to be ready for absorption, it has to bind to a factor called the intrinsic factor. Okay, the intrinsic factor is released from the parietal cells of the stomach. Okay, so it's released in the stomach, it binds to vitamin B12, and then the complex travels through the intestines to be absorbed in the distal ileum through binding to a special vitamin B12 receptor. Okay, so patients with disorders such as pernicious anemia, which refers to an autoimmune disorder that involves the destruction of the parietal cells of the stomach, will have lowered levels of the intrinsic factors. This means there won't be enough intrinsic factor to bind to vitamin B12, and that will definitely result in the reduced absorption of vitamin B12 from the small intestine. Similarly, a genetic deficiency or low activity of the intestinal B12 receptor can also result in poor or lower absorption of vitamin B12. Lastly, since we said that it's essential for vitamin B12 absorption that the intrinsic factor, which is released in the stomach, to be available, patients who undergo gastric resection, whether this was for gastric cancer or for bariatric surgeries or stomach reduction surgeries that are usually used to treat obesity, those patients will also be subject to vitamin B12 deficiency and anemia. Now, we said that, of course, vitamin B12 deficiency associated anemia is associated with the general signs and symptoms of anemia, such as dizziness, headache, palpitations, pallor, etc. But vitamin B12 deficiency anemia may cause neurological symptoms, such as tingling in the tips of the fingers and the hands and feet. Okay, we call that neuropathy. They can also be associated with difficulty walking or abnormal walking. We call that ataxia. They can even, patients with vitamin B12 deficiency can even develop dementia and even extreme hallucinations and paranoia, leading to psychosis, okay, or schizophrenia. So severe vitamin B12 deficiency is a very serious problem. Remember here that vitamin B12 deficiency is another cause of megaloblastic macrocytic anemia. This means that both folate and vitamin B12 deficiency can cause this type of anemia, megaloblastic anemia. And that means that if you administer folic acid for the treatment of megaloblastic anemia alone, okay, that will definitely correct the anemia even if it was caused by vitamin B12 deficiency. However, correcting the anemia using folic acid alone will mask the vitamin B12 deficiency that can, as we mentioned, proceed to severe neurological dysfunction and disorders. Okay, let me say that one more time, is that if the anemia is caused by vitamin B12 deficiency, it will present as megaloblastic anemia. And if you use folic acid only to correct it, that will correct the anemia, but it will not correct the underlying cause, which is vitamin B12 deficiency. This means that it's very important that in cases of megaloblastic anemia, you should be able to determine carefully what is the main cause. Is it folate deficiency or vitamin B12 deficiency, in order to be able to treat the patient properly. And that is also why megaloblastic anemia should not be treated with folic acid alone, but rather with a combination of folic acid and vitamin B12 together if you were not sure which one of them is causing the anemia. Again, here remember that the main absorption site of iron is the duodenum, for folic acid is the jejunum, and for the vitamin B12, it's the ileum. To correct anemia caused by vitamin B12 deficiency, vitamin B12 can be administered orally or intramuscularly. Okay, usually the oral preparations of vitamin B12 are used for the treatment of vitamin B12 deficiency caused by reduced dietary intake. Okay, there is no problem with the absorption, no malabsorption or intestinal pathology, so you can replace vitamin B12 orally. But in patients who have other disorders such as pernicious anemia, malabsorption, or have undergone ileal resection, they undergone some surgical removal of parts of their small intestine due to whatever reason, those patients will not benefit from oral vitamin B12 because they won't be able to absorb it. That's why we use parenteral or intramuscular iron to correct that. Hydroxocobalamin is a vitamin B12 preparation available intramuscularly and usually results in rapid response and corrects anemia caused by vitamin B12 deficiency fastly. Cyanocobalamin is given orally on a daily basis as a daily dose and can also be given once monthly as a parenteral injection. Okay, let's discuss a question based on what we've learned on megaloblastic anemia. A 56-year-old female is discovered to have megaloblastic anemia. Her past medical history is significant for alcoholism. However, that is not enough to tell you whether the cause was folic acid deficiency or vitamin D deficiency, because alcoholism can result in both conditions. Okay, you're not sure. You did not run lab tests to confirm which vitamin is causing the anemia. So the question asks you of the best treatment approach for this patient. The answer to that question, especially that you're not sure which vitamin deficiency is causing this megaloblastic anemia, you would always need to use a combination of vitamin B12 and folate at the same time. Okay, so the answer to this question is D, because if this anemia was due to vitamin B12 deficiency and you treated with folate only treatment, you will definitely correct the anemia, but you will not correct vitamin B12 deficiency, and that can progress into life-threatening neurological disease. Can even progress to paranoia and schizophrenia. Let's now move on to discuss the use of erythropoietin and darbepoetin for the correction of anemia. I'm pretty sure you all know that in response to hypoxia, peritubular cells in the kidneys synthesize and release erythropoietin, which is a glycoprotein that is responsible for the stimulation of stem cells to differentiate into proerythroblasts, and that promotes the release of reticulocytes from the bone marrow. as well as it contributes to the initiation of hemoglobin formation. So erythropoietin is very essential for red blood cell proliferation and differentiation in the bone marrow. This means that we can use erythropoietin therapeutically if we want to correct anemias caused by dysfunctional RBC production. Now we can synthesize human erythropoietin called epoietin alpha. This is the drug name. We can synthesize this hormone artificially using recombinant DNA technology. Okay, and that's why epoietin alpha or recombinant erythropoietin is effective in the treatment of anemia caused by chronic kidney disease or end-stage renal disease, anemia associated with HIV infection, anemia resulting from bone marrow suppression, usually that happens following the use of chemotherapy, for example, for the treatment of cancer. Erythropoietin is successful in stimulating bone marrow to start producing red blood cells again. And lastly, erythropoietin can be used for the correction of anemia caused by cancer. Erythropoietin is only available intravenously and is usually combined with parenteral iron supplementation. Remember that one of the indications that we mentioned for IV iron is to be combined with erythropoietin to achieve better therapeutic outcomes. Now, on the other hand, darbepoetin is a long-acting analog of erythropoietin that has a longer half-life, meaning that darbepoetin can be given at less frequently to patients than epoietin alpha. Note here that both erythropoietin alpha and darbepoetin are well-tolerated drugs and administered intravenously in renal dialysis patients or subcutaneously for other indications. These drugs usually have minimal adverse effects, and those include hypertension and arthralgia that we will discuss later. Finally, remember that both epoietin alpha and darbepoetin are not useful for the correction or the treatment of acute anemia. All the conditions that cause anemia can be treated by erythropoietin include chronic diseases such as kidney disease or chronic HIV infection or cancer. Can you think why erythropoietin won't be useful for the treatment of acute anemia? For example, anemia resulting from acute blood loss? Despite that it's an effective drug and is usually associated with minimal side effects, there are several recommendations and guidelines that should be followed in patients receiving epoietin alpha or darbepoetin to avoid life-threatening or poor outcomes of therapy. So, in order to treat a patient with erythropoietin, you will have to use a dose that does not exceed hemoglobin level of the patient above 12 gram per deciliter. Okay, so as you initiate the treatment with erythropoietin, you will also measure hemoglobin levels consistently. And the dose that you use of erythropoietin to correct the anemia should not increase hemoglobin levels of more than 12 grams per deciliter. And the reason behind that is that serious cardiovascular events such as thrombosis and severe hypertension, increased risk of death, shortened time to tumor progression in case the patient had cancer, and decreased survival have all been observed if the treatment with erythropoietin was too fast and elevated hemoglobin levels more than 12 grams per deciliter. Another guideline is that the dose that you should be using should not result in an increase in hemoglobin level of more than 1 gram per deciliter over 2 weeks period. If that exceeds that limit, it means you're treating the anemia too fast, and that will be associated with all the adverse outcomes that I just said, okay? So you can't go above 12 gram per deciliter, and you will have to increase hemoglobin very gradually of no more than 1 gram per deciliter every 2 weeks. If hemoglobin starts rising above 10 gram per deciliter, the dose of erythropoietin must be gradually reduced, okay, so that you won't reach the maximum limit of 12 gram per deciliter so fast. These guidelines of how to use erythropoietin are very important. As I mentioned, erythropoietin in general is safe as long as it's used based on those guidelines, but it can be associated with edema, elevation in blood pressure that is usually caused by increased peripheral vascular resistance or even increased blood viscosity. Patients on erythropoietin therapy can also suffer from arthralgia. And as we mentioned, that if erythropoietin resulted in a rapid increase of hemoglobin of more than 11 to 12 grams per deciliter, this will be associated with severe thrombosis and increased risk of death and poor therapeutic. Now, moving on, discussing a group of drugs that are useful for the treatment of neutropenia or reduced neutrophil count in the blood. Now we're talking about disorders of white blood cells. There are several compounds that exist for the correction of neutropenia. For example, filgrastim, TBO filgrastim, and pig filgrastim. All these drugs are analogs of the granulocyte colony stimulating factor, GCSF. That is the growth factor associated with promoting the proliferation and differentiation of white blood cells. Sargramostim is a granulocyte macrophage colony stimulating factor, GMCSF, which is another hormone that is also important for the proper production of white blood cells. So these drugs basically mimic the effect or the role of these agents in the body, and thus they can stimulate granulocyte production in the bone marrow. Usually, patients with chronic malignancies or receiving cancer chemotherapy will develop bone marrow suppression, right? A reduced function of bone marrow, which results in anemia for sure. But at the same time, it also results in reduced white blood cell count, especially neutrophils. That's why cancer chemotherapy can cause neutropenia. And for that purpose, we can use these drugs as prophylactic therapy when we give chemotherapy to those patients to avoid uh, uh, bone marrow failure and reduced number of white blood cells. And for that, filgrastim and sargramostim can be given intravenously, while TBO filgrastim and pig filgrastim are only used subcutaneously. And the way that we administer them is that all these drugs, filgrastim, TBO filgrastim, and sargramostim, are given once daily, 3 days after chemotherapy is given to the patient. Okay, so you will start treating cancer with chemotherapy, wait 2 to 3 days, and then start giving these agents to help the bone marrow to generate white blood cells after it has been damaged by the chemotherapy. And we usually stop these treatments when the neutrophil count reaches 5,000 to 10,000 cells per microliter. So you have to measure that to follow up with this treatment. On the other hand, pegfilgrastim is available as a single dose given only 24 hours after chemotherapy, and it has a long-acting effect, which means you don't have to keep frequently dosing uh, the drug after chemotherapy. These agents, since they stimulate bone marrow function, they can be associated with bone pain as an adverse effect. Lastly, there is no evidence to show superiority of one of these agents over the other in terms of efficacy or safety, and you can use them all depending on the patient's characteristics and the availability of these drugs for sure. Last topic in this presentation is on hydroxyurea. Hydroxyurea is basically, it's an anti-metabolite drug that has been long used for the treatment of cancer. So it's basically an anti-cancer drug, and it exerts that function by inhibiting ribonucleotide reductase, interfering with DNA synthesis in tumor cells. However, we can also use hydroxyurea for the treatment of sickle cell anemia. We don't basically understand how hydroxyurea exactly exerts its effects for the treatment of sickle cell disease, but we know that hydroxyurea results in an increase in the levels of fetal hemoglobin, hemoglobin F, which results in the dilution of the sickled hemoglobin or hemoglobin S, which is responsible for the sickling of red blood cells. And this results in a reduction in the polymerization of hemoglobin S, reducing the sickling and painful crises associated with sickle cell disease. In most cases, hydroxyurea would require 3 to 6 months to be able to reduce the frequency of painful episodes in patients with sickle cell anemia. And we know that following 12 months of therapy, around 70% of treated patients will start developing a significant reduction in the frequency or the development of painful episodes as they are being treated with hydroxyurea in comparison to no treatment. However, hydroxyurea should be prescribed by a hematologist or a specialized pediatrician using very careful criteria, and it can only be used in patients that develop frequent painful episodes, okay, 6 or more per year. So you have to use it in advanced cases. You can also use hydroxyurea in patients who developed acute chest syndrome, and this results from the sickling and occlusion of red blood vessels in the supplying the heart. If the patient has a previous history of severe vaso-occlusive events, then they can also be given hydroxyurea. If they have severe symptomatic anemia, this means these criteria mean that you will reserve hydroxyurea for the treatment of severe sickle cell disease. Of course, hydroxyurea has some side effects like other chemotherapeutic agents. It will definitely suppress bone marrow function, which can sometimes exacerbate the anemia, and it will result also in a condition called cutaneous vasculitis, which is basically describes the inflammation, painful inflammation of small peripheral blood vessels. This table summarizes the main adverse effects, drug interactions, things that you should worry about when using all of the agents that we have discussed in this presentation. So please take a look at it. And if you have any questions regarding this presentation, please don't hesitate to get in touch with me via email or through Microsoft Teams, and I'll be happy to answer any question. Thank you.